Hello and welcome to the Tissue-i series of webinars. This is hosted by GenQA and today we're focusing on ovarian cancer, the tumour assessment for molecular testing. We're joined by two experts within this field and who are members of our GenQA Tissue-i expert panel, and that's Dr. Anka Onescu from Edinburgh and also Dr. Philippe Tania from Birmingham. I'm Sandy Deans and I'm Director of GenQA, and we're also joined today by Abby Trosh, who is the GenQA Tissue-i EQA lead. So we're going to cover a very brief introduction about what Tissue-i is and how it's delivered and how it benefits participants. We're also then going to move over and hand the webinar over to our two experts on the panel to give us an in-depth review of 6 of the Tissue-i ovarian cancer cases that have previously been used for the EQAs. And then we'll have a live Q&A session, so you have an opportunity to ask your questions to our expert panel. So please do submit your questions through the Q&A session function on the webinar, and hopefully we'll be able to answer your queries as we reach that part of the webinar. Thank you. So what is Tissue-i? Well, really this is a module, an online module that has been set up by GenQA to help support and standardise histopathology tissue assessment for genomic testing. There are different modules. We now have 9 and they cover different tumour types, and the idea of having individual modules is so that individual participants do not have to assess tumour types that they potentially not used to looking at and reviewing for molecular testing. So you can really just use the modules to adapt them to your own expertise. It's not a lab-based exercise, it's for individual participation. And because of this, we don't assess any performance. Really, it's about benchmarking exercise for educational purposes. So each individual can actually see where they are in relation to other colleagues when it comes to assessing tumour content and cellularity. This was initially set up for the 100,000 Genomes project through NHS England funding, and this is now continued, and we're expanding the different tumour types available for assessment, and NHS England funds any of the NHS England Genomic Laboratory Hub participants. We set the system up in collaboration with PathXL because they had their TissueMark tumour assessment module, which helped us determine the actual tumour content within the cells in the slides. PathXL was then taken over by Philips, and it's now owned by Ceridan, and we still work very closely with that system. You can see here that we have images that you can increase the magnification and move around as you would on a normal microscope, and also just ask some questions here that's listed on the left hand side. The first one being, is this tissue suitable for molecular testing? And then we can ask and determine the tumour content and also the cellularity, and mark up areas for macrodissection if that's appropriate. We always get asked, and it's a very, very valid question, how do we know what the correct answer is? And it is very difficult to come up with some sort of expert value because it is subjective. So for tumour content and cellularity, we tend to use the consensus estimation of the participants, and also link this into the panel review of the individuals who we know routinely assess tumour content of diagnostic samples for molecular testing and have a huge range of experience, and particularly in those specific tumour types. So between the two of these approaches, we often come to the same answer, and we can be more confident that that is what we're looking for. Each participant receives a copy of an overarching EQA summary report, which is shown here on the right hand side on the bottom, and that gives you details of participation, the markups of the tumour for macrodissection, and the overall submissions for tumour content and cellularity from all the participants. So again, as I just mentioned, this is about benchmarking yourself against colleagues. Each individual also receives their own report, which details what they have marked up themselves and what their own percentage estimations were. So again, you know exactly what you submitted, and you can use that to benchmark. So I've got a couple of graphs and results to show you now, which have been submitted from previous EQA runs. So this is from this year's EQA run, which is 2021. So these are the summary of tumour nuclei estimations across the whole tumour slide that is provided. So everyone is looking at exactly the same image and the tumour section for analysis. These are two different cases that was supplied this year, as I say. The black arrows indicate the tumour content estimated by the expert panel. And you can see on the left-hand side here that the majority of participants also agreed that the tumour content was around the 50 to 60% mark. However, there is a huge range either side of this, predominantly with most participants estimating a higher tumour content. The case on the right-hand side here, again, the expert value was around the 51 to 60% mark, but again, the majority of participants stated that there was over 80%. So I think we've got better correlation of percentages for ovarian at the moment compared to some of the other tumour types, but I think there's still some work there to be done to standardise as we go forward. The other area that we look for consensus in this EQA is about marking up areas for macrodissection. Now, this is something that had never been done before, so we were really quite keen to find out if there was standardisation or not. So these images are submissions from 4 participants. The 3 along the top are from individuals, so 3 different individuals. One on the left-hand side here, you can see have marked up the whole area of tumour, which has a lot of necrosis in the centre. So really that is not suitable, or really you don't want that in your DNA extraction sample. The individual in the middle here on the top has defined just a very small area, whereas the individual on the right-hand side has actually marked up a very, very defined area, which actually is where all the tumour is sitting. There's also different ways of marking up for macrodissection, and along the bottom here, the 3 images were submitted from a single participant who have marked up 3 very discrete areas for macrodissection. Now, the most people in the laboratory know that it's very difficult to scrape off accurately particular areas of the tissue from a slide, and I think particularly the one on the bottom left would be quite difficult to do this in the laboratory. However, this lab may be using cores or different ways of working, in which case this is probably a very practical way of going forward. So that's why we don't assess performance in these EQAs, because really it dependent on local practice and local protocols in place, and really we don't want to disadvantage anyone because we don't know what's happening actually in the department for these tissue types. However, I would say that as time has gone by, we are getting really good consensus, particularly for the ovarian cancer EQA cases. And here you can see that we had huge consensus, everybody in this particular case, to say you mark up the whole slide or just no macrodissection and use everything for the DNA extraction assay. So I think there's definitely good news that standardisation through participation in the Tissue-i EQAs is improving what we are doing. So through the years, we've been offering different tumour types, as I previously mentioned, and we've been expanding this. Really, we have a core set of tissue types that we like to provide every run, and that's colorectal and lung. And the colorectal was then introduced and expanded to become gastrointestinal tract cancers, and we rotate between upper and lower on alternative runs. In a similar manner, we changed the ovarian EQAs, which were run in 2016 and 2017, to actually expand and become gynecological tract EQAs. And a lot of the cases from today's webinar have been taken from these EQAs. Also, prostate is now become urology, really just to expand the cases that we can provide for the EQAs, and breast, melanoma, sarcoma, CNS and pediatrics are those tissue types that we rotate. So we do try and have enough cases and tumour types included so we can offer this EQA to as many individuals as possible. So I think through the years we have determined that there is variability and lack of concordance, both on the estimation of tumour cell content and also cellularity, in other words, the total number of cells present. Also, we saw variability in areas to be macrodissected, but I think this is becoming much more standardised, and that's a very successful story for Tissue-i EQAs. So I think the way forward is standardisation through education and training. And this is EQA participation is an easy way for this to be delivered. And we think the EQA feedback and continual participation through the years does actually drive up the standards, which is good news for the patients who have to go through these types of tests. So that is a very quick review of what Tissue-i delivers to you. And now we're going to go to our expert review panel, who are going to work through 6 of the ovarian cancer Tissue-i EQA cases that previously been used in the runs. So I'm now going to hand over to Philippe and Anka. So if I hand over to you, Anka, now to kick us off with the first case review, please.
Thank you very much, Sandy. Yes, so the first case for this gyne run is an omental biopsy, as we have been told in the clinical summary, and it's a previous diagnosis of a high-grade serous carcinoma. And because these patients don't need molecular testing, particularly with a focus on BRCA testing these days, we get a significant number of these biopsies coming in for molecular testing and marking up of the tissue. So in biopsies like this one, it's we can see there are some areas low power that we can see some condensation, and almost, as we say, it looks a bit more blue in some areas. So those are the areas that we would have to go high power in and try to assess the tumor. The challenge we would have with some of these cases is trying to see if the patient had previous chemotherapy or not, if there is fibrosis or associated inflammation. Sometimes the amount of tumor may be quite scanty. So if we would go high power on these areas, it's quite easy to see the solid and almost microcystic tumor that's present there. It is the morphology, not disputing any of the high-grade serous previously diagnoses that's been made, but there is a little bit of inflammation around the tumor. We can see lymphocytes, we can see some tiny foci of calcification as well, and some bigger nuclei that are very characteristic for the high-grade serous. And there is significant amount of tumors. So I think the challenge on a case like this is making a decision if we need to macrodissect, and if we would need to macrodissect, going to the areas that are actually important in terms of making sure that the area is large enough and not posing a challenge for the technical staff in the lab, because sometimes you can come up with some drawings that can be quite impossible to follow. So these look quite good, big areas to be able to macrodissect. And as we have estimated as a consensus expert group, we thought that the tumor percentage in this particular case is between 50 and 60%. So it's a good percentage in terms of tumor that would be suitable for most of the platforms that we are using. I cannot see any tumor necrosis that's significant, and this would be one of the other factors that one perhaps may want to exclude. And again, making sure that there is quite, that once we have chosen a percentage that we are happy, it's pretty representative in most of the areas. And in terms of the cellularity, that's the other thing that we sometimes can comment on. It's perhaps in these omental biopsies that have significant tumor, not a big challenge. It's estimated as being high, which means more than 10,000 tumor cells. I'm not sure if we would provide necessarily a guide to this, but I tend to use the fields from lymphoma IFAM to assess cellularity in these areas. So it's a very rough guide and a very rough estimation that in a ×20 field that's got quite uniform cellularity and a mix of kind of bigger tumor cells and some stroma in the background, we can talk about maybe having between 2,000 and 2,500 cells. So if we would go around the field, it's quite easy with that rough estimate to say where we are in terms of cellularity for these tumors. It may look slightly bigger on the screen, but the sample is quite good percentage. And the slide is just moved now in an area that there is a little bit more inflammation, but it balances as an overall with the amount of tumor that's adjacent to it. Thank you.
Do you think it would very much affect and compromise the accuracy of the results of the testing to follow if we were not macrodissecting in this case? Because I don't think fat is highly cellular, is it?
No, the sample doesn't really contain a lot more apart from the tumored lymphocytes. So it's the high cellularity that we have as 50 to 60, it's pretty much concentrated in the areas of tumor. If there would be a lot of inflammation in the background momentum and maybe a quite reactive proliferation of the mesothelium, which we sometimes see in metastatic disease, I suspect that sample may be more suitable for macrodissection. But in this particular case, one can balance that the high areas of tumor actually, even if we would try to say as an estimate that it would go down another 20%, we will be somewhere around 40% tumor as an overall, and therefore still have sufficient tumor for most of the platforms that we currently use. And a 40% tumor in a whole section actually may make life easier in the lab and have a faster turnaround time overall.
Okay. Oh yeah, thank you. That's very helpful. Thank you very much, Anka.
Thank you. So we'll now move on to case 2. Anka, back to you, please.
Thank you. Yes, so this is a very good size biopsy. It's a presentation in a lady with postmenopausal bleeding and diagnosed as an endometrial carcinosarcoma. So we can see there is a lot of hemorrhage in the section. There are also fragments of tissue that do look very low, but look malignant, low power. And again, if we go high power and try to see what is present in that biopsy, and now it's right in the area of interest. We can see a glandular tumor, and adjacent to it, right deep into the stroma, there was a more spindle cell proliferation present there as well. There is quite a bit of inflammation as well in the biopsy. The blood does not contain significant number of lymphocytes or other cells that would actually make our percentage of tumor significantly reduced. And if the panel has agreed that this would be a tumor content in the whole slide of 60 to 70%. I think what would one do in these situations, because macrodissection is possible, that actually if we're scanning the whole section, making sure that we are not going to encounter some huge lymphoid aggregates or areas of tumor that may look slightly different, or some endocervical tissue, for example, that could contaminate these samples, then it's just a matter of making sure that we do have homogeneity, if we can use that, in terms of the amount of tumor that is present in most of the fragments that we have sampled. Some of these cases may also have immunohistochemistry done. We now do mismatch repair immunohistochemistry to look for Lynch syndrome screening, and also immunohistochemistry in-house for the p53 mutant status. That's important for treatment purposes, but they may also go for polymutation, as this would be graded as a high-grade tumor, and perhaps the endometrioid component in the background would make one think that would require polytesting as well. So cellularity is the next thing that one would want to comment, and it's quite easy to see that there is plenty of tumor in the section, and the cellularity would be considered as very high, which equates to more than 50,000 tumor cells. A good sample for testing, and nothing to really leave out in terms of the material or the tissue, so no macrodissection required for this one. Thank you very much.
Thank you, Anka. And now we have case 3 here on our screen.
Thank you. So this is, again, another lady with a biopsy that has been taken previously 5 years ago, as she was diagnosed with malignancy and a high-grade serous carcinoma. Now she's had relapse disease, and therefore the biopsy becomes important in terms of looking for mutations that could help with further management, i.e. doing BRCA mutations or HRD testing if that would be required. And the tissue that we sometimes use in these situations actually is diagnostic, or the debulking material, as we call it, in terms of the more specific gynecological term on these cases. So we do have a fragment of tissue of tumor, probably omentum as well, but that there are some areas that look very light, very blue in color. So one would have to go really high power and try and see, is it calcification? Is it Samamoto's calcification, something that we see quite often in high-grade serous carcinomas? And is there any tumor lurking in the background that would need to be selected for testing? So as we can see on the screen, there is a little bit of a mantle fat that looks uninvolved, but there is significant fibrosis and also significant inflammation. And these blue dots, the calcification, Samamoto's calcification, that are actually the ones that look very blue, low power when you looked at the slide. If we stay in this field alone, we can see that the center of the image actually contains significant inflammation and fibrosis, and we can only see a few glands, quite ill-defined and light blue, that are scattered in between. So in terms of the tumor cellularity, that becomes quite low, because if we look at the whole section, only part of the section contains tumor that's slightly higher. So the expert panel has agreed that this is a tumor with cellularity between 1 and 10%. Naturally, the next question would be, would we put it down for testing, and we would do macrodissection? And yes, we would macrodissect to choose the areas that have a slightly higher amount of tumor, like the area that is marked on the screen just now. And that is also to avoid the calcification that may impact on doing the actual DNA extraction on this sample. So the other thing to maybe think about is that we sometimes try to be quite precise in terms of the macrodissection, as I've made a comment on the first case, but choosing a larger area to have sufficient DNA, hopefully it will give us a good deterrent in terms of not trying to be too specific and actually missing areas of tumor on the slide. The cellularity on the whole slide is very high because the stroma, despite looking not very cellular, there is significant inflammation in it, and it's considered to be more than 50,000 tumor cells and total cells actually in the whole section for this particular case. Thank you.
Thank you, Anka. Philip, is there anything you want to add?
Thank you very much, both of you. Yes, question I think we could, I don't know if there is a clear answer, but if you had choice between testing on the diagnostic biopsy prior treatment, assuming there is enough tumor, and this specimen post-treatment, would you have a preference? This is a question we've been asked quite often. I'm not sure there is an answer to that, but what is your experience and opinion about it, Anka, please?
Yes, I think it all depends on the size of the tissue. And so if we would have, for example, this is the pre-treatment sample, the debulking sample, for example, and we know there is tumor that is not very good or brilliant tumor percentage, we can say, because it's estimated in the whole section as only 1 to 10, probably go slightly higher, maybe pushing it to 15 to 20 in the macrodissected part. And we know this is good tissue. If the diagnostic biopsy, when the lady relapses 5 years down the line, is a tiny biopsy or maybe cytology sample, then that sample would quite likely be insufficient to be able to do not just BRCA, but look at HRD testing and see how that could be done. So we know that requires slightly more tumor and more DNA in total to be able to offer a good test. So I would prefer the most recent sample, but it all depends on the size. I don't think the treatment would put me off in choosing the previous sample, because in terms of either picking up a germline or trying to suggest a germline, or also picking up a somatic mutation, those samples are quite good. And sometimes the debulking samples can have quite significant amount of tumor that makes them better for molecular studies. One comment, I wouldn't go maybe 10 years or 15 years back, because the age of the tissue block sometimes can impact on the quality of the DNA. And if we need to do RNA testing, that's something that has to be considered as well. So the age of the block would be something that would make me less happier to choose a very old case.
Yeah, thank you very much. That's very, very helpful.
Thank you both. So now moving on to our fourth case. Anka, will we come to you first, please?
Yes, thank you. So the next case, we can see a few fragments of fallopian tube tissue, and adjacent to them, there is something that looks quite complex in terms of the morphology, glandular and papillary on the surface. So when we would go high power onto this particular case, we can see right in the center of the field, there is necrotic material, but surrounding the areas of necrosis, there is quite significant amount of tumor. We can see some punched out, almost microcystic spaces in this tumor. It does look morphologically like a high-grade serous carcinoma, and the adjacent of the fallopian tube is also quite good in terms of knowing that the fallopian tubes are actually the site of the primary site for these high-grade serous carcinomas and the occurrence of these tumors. We don't call them ovarian or peritoneal anymore. That's more of a type of spread of the disease. They are known now molecularly to actually occur from the fallopian tubes. So quite a papillary fragment of tumor. You can see here the line that's used for macrodissection has actually left out a little bit of necrosis for that particular tumor, but overall, all those glandular areas and some of the solid areas show pretty good tumor percentage overall. The panel has estimated that this tumor, that's the slide and the area marked in particular, is quite good tumor percentage, going to 70 to 80%. And if we go back low power, we can see that we have left out the normal fallopian tube in the background. That would be the muscle and the tubal epithelium that would actually make your overall tumor percentage to go down. One thing to consider again, as we've done in the previous case, is the amount of tumor sufficient to actually take the whole slide, or would we leave out the normal and just concentrate on the tumor? It won't be that hard to actually just remove the tumor from this slide because the fragments look pretty good in terms of the size. So I would suggest perhaps in cases like this, still go for macrodissection because you probably don't need more than a couple of sections and removing the tumor from this particular case. In terms of the whole cellularity on the slide, it is very high. It's a good sized tumor. So that would be a case that should not pose any problems in terms of molecular testing. Thank you very much.
Thank you. So we'll now move on to case number 5.
Thank you. So this lady has presented, as you can see, with lower abdominal pain and feeling sick, and the fragment that we've got, it's an omental, another peritoneal/omental biopsies. They're quite easy to obtain through a laparoscopic procedure in this patient. And we can see there is background normal fat with some islands of apapillary and quite characteristic high-grade serous tumor surrounded by a bit of fibrosis and some minimal inflammation. So I would go slightly higher power on cases like this one, just to make sure that there isn't a lot of inflammatory background within the stroma, within the fibrotic stroma. And we do have these papillary clusters, the tumor, the punch-out spaces, and we can see that the inflammation is present focally, but it's not a lot of inflammation. It's mostly fibrosis that we can see. Obviously, it does add to cellularity, which explains why the overall cellularity in terms of the tumor cellularity in the sample has been decided as 60 to 70%. So that 30% would account for the fibrosis and some of the inflammation that we can see. Quite good tumor, and the tumor looks characteristic. There wouldn't be any other issues in terms of trying to macrodissect on the slide because it's quite homogeneous, and the areas that are present between these tumor clusters do not pose a lot and do not show a lot of increased cellularity to be able to suggest macrodissection. So if we go back low power, we can see that actually the parts of the peritoneal tissue or the fatty tissue that's present are actually very, very low cellularity. Those punched out spaces are not going to be, the fatty cells are not going to contribute significantly. There is absolutely no need to macrodissect on this case. And in terms of the overall cellularity is very high. It's a very good size fragment of tissue, and with more than 50,000 cells in total. So a very good case for molecular testing to take as a whole section, and with very good tumor cellularity overall. Thank you.
Okay, so now we've reached our final case. Anka, do you want to give us your review, please? Yes,
thank you. So this last case is a section of an ovarian tumor that was diagnosed in a 72-year-old lady who's presented with postmenopausal bleeding. So we can see that there is significant amount of tumor that looks quite solid on the section. There are some areas that look slightly different, nuanced, slightly different color around the tumor, and those are the areas that show some lymphocytic infiltration. That's a lot of tumor, some central necrosis in some of these areas, but the tumor cellularity seems to be very, very high. There is a lot of solid tumor nodules, and some areas with very little stroma in between these tumor nodules. The areas of necrosis are present centrally, so I don't think it's really worth considering leaving out any of this necrosis. And it's not very significant. It's not something that really is present in large parts of the tumor section. In a large case like this, I suspect I would try maybe sometimes to correlate with the immunohistochemistry sections, if there's been any, because the fixation could be one of the things that one would have to consider. So you may have a very, very large section and a very good tumor cellularity, which, as we estimated in this case, is 70 to 80%. But when we do some of the other immunostains to confirm a histological diagnosis, one may find that the P53 or the ER or the WT1 for that matter may show slightly condensation or an increased pattern of staining right at the edge of the tissue section, which would make us think there is a fixation problem. So if that is the case, don't be surprised if your overall tumor DNA that you measure at the end of your DNA extraction may look low, because that can be caused by fixation of the actual tissue. Sometimes going to a fragment that, for example, one may have done a frozen section on and maybe fixed slightly better may actually sort that problem. Overall, not a case that should pose issues in terms of your tumor percentage and the overall cellularity, which is very high, more than 50%, more than 50,000 tumor cells and cells in general in total in this whole section. And that's all for this case. Thank you very much.
Anything from you, Philippe, on this final one?
No, thank you. No, the fixation is a very good point for gynae. But sometimes, we receive specimens from outside. Okay, for MMIs now, we have our distinguish between zonal effect or fixation artifacts, but it's quite impressive how poorly fixed they are. Anyway, but as you said, that ovarian cancer is probably less an issue because
Great, thank you very much, both of you. That was incredibly interesting, and there's some comments here in the chat and questions thanking you very much indeed. So can I now come to you? We've got quite a few questions that have been submitted, so really I'm going to pick your brains and ask you if you can help out. So really the first one is quite a general one here. So what changes have you seen since molecular testing has been introduced for ovarian cancer patients? So we know, molecular testing has been around for quite a long time now, particularly for GIST and lung and melanoma and everything else that we do routinely. But ovarian has sort of come along as a quite recently relative in the world of molecular pathology. So what changes have you seen, and sort of how has that been introduced in your view? Anke, we'll come to you first, please.
Yes, the most significant one is actually BRCA testing that's been driven significantly by PARP inhibitors now being approved for these ladies when they are advanced stage. And it has changed from perhaps giving in the later stages to now being considered earlier on in the treatment, because most of these patients actually present in stage 3C disease when there is already a mental disease there. Not that much for BRCA germline testing, even though if no somatic mutation is picked up in the tumor, and if there was no previous germline testing done on these ladies as part of their referral pathway to investigate a BRCA mutation, a BRCA germline mutation, then it's worth actually considering a germline mutation as well if that's not been done. One other test or one other consideration to give to these biopsies is that sometimes there could be diagnostic challenges, and we can not always say if it's a low-grade serous carcinoma or a high-grade serous carcinoma, and the importance of that is very much treatment driven, because the low-grade serous patients do not need chemotherapy now, in contrast to the high-grade serous patients, and they have a completely different molecular phenotype. So for any cases where you have a challenge in the size of the nuclei, or it's not a mitotic tumor, or you may consider, you may have a difficulty into what to call it because your immune of a p53 doesn't come back. We have done quite a few of these cases have gone on to the NGS for KRAS and BRAF mutations that one can find in low-grade serous tumors, and also to confirm if there is a p53 mutation, which would make it more placed into the high-grade serous tumor category. And then that will drive BRCA mutations further down the line and so on, because the high-grade serous are the ones that tend to have a higher percentage of BRCA mutations.
So sometimes it's about having more of a strategic testing pathway, isn't it, to get to the answer? Yeah, great.
And to be able to say what treatment the patient needs.
Yeah, absolutely. Philippe, is there anything you want to add there? How have you seen molecular testing change the way that ovarian cancer tumour samples are handled?
No, I've got nothing. No. The only test we sometimes been asked to do in ovarian cancers on the top is like for any type of cancers and track, because the license is being given, at least in England, as an agnostic marker if you wish. Otherwise, no. Nothing to add. Thank you.
No, that's great, thank you. So a question a bit about, you touched on biopsy, so the sample that you're actually handling and using. So lung biopsies, we know that they're notoriously often very, very small and not always enough material there to actually perform all the molecular testing that you want to perform. Is that the same case for ovarian biopsies? Anka, we'll come to you first.
Yes, it may be for some cases. We see patients that sometimes are diagnosed just on a cytology sample, and there is an increasing need to actually follow that up if a diagnosis can be suggested on cytology, to then follow that up with a biopsy. And that biopsy is to simply also have access to testing, to molecular testing and BRCA. Now, soon we'll have to start offering HRD testing. So we know that the amount of DNA one needs for HRD testing is has to be a lot higher than one needs for BRCA. And if these patients actually are advanced stage, they may also need an NTRK fusion done at some point when all their options for other treatments have been exhausted. So now thinking about, from a single tiny biopsy, getting a quite significant, BRCA testing, HRD testing, then considering RNA sequencing as well, that amount of tissue may be insufficient. So not all patients are having surgery, not all patients are well enough to have debulking surgery, and consideration to a very good size biopsy, diagnostic biopsy, is important just in case you cannot get a surgical sample down the line.
Yeah, thank you, Anka. Philippe, anything to add there? Do you think we need to triage the order of tests if there's a limited amount of material? I know that would be very controversial.
No, we should find a way of not having to do that, I suppose. Absolutely. Like always, finding the balance between adapting the technologies to real life specimens. And favoring and concentrating first on what is clinically relevant for immediate patient's treatment. That's a triage, if you wish, not trying to do more than strictly needed for patient's management if it's for trials and research, if tissue is an issue. That's what the triage, I would say, is clinical triage, I would say, as Anka said.
Absolutely, thank you for that. And I guess we maybe need to look at HRD testing being performed in a different way. And I know there's a lot of global initiatives out there about alternative testing protocols. And if we can drive down the amount of material needed, then that would probably help an awful lot of patients as well. Yeah, great. Well, thank you very much indeed, both of you. That has been extremely useful. I've learned a lot, and I'm sure our audience has as well. We've got a survey going to be sent out to those who have registered, just to give us a bit of feedback about how we could maybe improve future webinars. You'll also get a participation certificate sent to you directly. This webinar will be available to view on the GenQA YouTube channel from the 3rd of January, early in next year. So you just have to click on the subscribe link on the channel and you'll be able to access it. We also have our prostate cancer tumour assessment webinar that has also been recorded a couple of weeks ago, and that will be available too. And just an advert that up and coming on the 10th of December, we will have a Tissue-i lung cancer tumour assessment webinar to which you're all invited as well. So thank you once again to Anka, Philippe, Abby for sorting out the webinar, and of course you for joining us this afternoon. Thank you very much.
Thank you very much, Tony. Thank you all. Goodbye.
Bye-bye.
Bye.